I'm presenting another DMEK corneal graft, however this time slightly different from the ones I presented before. In the beginning I'm just showing you the standard routine preparation of the donor tissue. I use membrane blue to stain the endothelium and then use a Sinski to score. If you notice that when I'm scoring I try and rotate the graft rather than move the Sinski itself, and I try and make sure that it's the same distance away from the periphery all the way around. And once we've done that, I stain the edge of the scoring marks to highlight them, and then I use a Sinski to lift the edges up to make sure there's no tiny tears or breaks. Now that I've done that, I'm using the special DMEK forceps to peel the decimes and peel the DMEK, and then I'm going to place it back in position with BSS with a no-touch technique, and then dry away the remaining fluid. This can be a bit fiddly at times, but it's best not to touch the graft and just use the fluid to push it back into position. It's important after this point to dry the fluid away, and then you can do the trephine. And again, you don't want to do a full thickness trephine, you want to do a partial thickness trephine so that you just make sure that the DMEK graft itself has been trephinated. If it does go full thickness, it can be a bit fiddly to remove it, but it's just important to try and lift it up without lifting the graft up with it. So here I'm just identifying the opposite end of the membrane, and then I'm doing the asymmetrical cut, which gives me a idea of which way around the graft will be in the eye. I make sure that the cut is full thickness, and then I peel the remaining half of the decimes membrane, and this completes the DMEK graft preparation. And then I put some tissue medium in while I'm doing the corneal work on the patient. So here you can see the patient's got a very significant amount of epithelial scarring. The Tux knife is very useful in removing the significant scarring from the chronic corneal decompensation. You can see as well that the cornea itself is quite edematous. I'm anticipating that the DMEK graft, as the primary pathology is from the endothelium and the cell loss, that the DMEK graft will gradually clear the cornea, as there is quite significant corneal edema. I'm now making marks for the entry point at 2.4 millimeters and the 2 paracentesis as well. I found it very useful to mark the 9 millimeter dermatorexis, as the donor graft is 8 millimeters in this situation, and you want to make the dermatorexis bigger than the size of the graft in DMEK. So here I'm doing the 2-step incision, making the tunnel quite short with the keratome, and I will fill the AC up with Provisc. I've also already done the peripheral peripheral iridotomy with the anterior retractor, and I'm using the reverse Sinski to score the endothelium, the decimes, and do the dermatorexis. I try and use just the Sinski to do this, so I score all the way around without pressing upwards too hard, as you don't want to score the stroma as well. And in this case it was quite easy to remove the endothelium and the decimes, as there was quite chronic corneal decompensation and quite thickened scarring. And you can see the membrane peeling away nicely, trying to make sure there's no tears or breaks while I'm doing this, and make sure there's no residual tags. I always in the DMEK do this under Provisc or some equivalent viscoelastic. I very rarely use a AC maintainer, unlike with a DSEK where I use AC maintainers to do this step. Now here I'm using bimanual IA to remove the viscoelastic and remove any tags that may be there as well. It's crucial to make sure that all the viscoelastic has been removed, and make sure the pupil is small, as there is already a peripheral iridotomy in place. I make sure that I do a thorough irrigation aspiration and remove any tags that may be there as well. And here you can see that the view is quite limited of anterior segments, so my concern here is whether I could visualize the DMEK tissue going in, and this is where I stained the donor tissue for 3 minutes with membrane blue. Once I've done the irrigation aspiration, and I'm happy with the removal of all the anterior chamber viscoelastic, then I go on to pre-place the 10-0 nylon at the main wound, and I use a Sinski again to pull away a loop so that I could pre-place the suture and then tie it immediately after placing the graft in position. So here you can see how long I took to do the irrigation aspiration, and here, because the AC is not refilled, you can see the creases on the cornea, and I'm placing the suture in place and pre-placing this, so I'm not tying it until I've injected the graft. And I'm being very careful not to create any bleeding from the suture itself. There might be a tiny bit of oozing, but you definitely don't want to catch anything on the way through. This gentleman's already pseudophakic and unfortunately developed significant corneal edema following cataract surgery done elsewhere, and he had a prolonged delay in his referral before he was seen by our corneal team. Here I'm getting ready to inject the DMEK graft, which I've already placed into the goiter cartridge, and I've just filled up the AC a little bit to give me a little bit of leeway. And I'm getting ready for the injection, so here you can see the injector going through into the wound, and I'm going past the pupil and gently injecting. This shot out quite quickly. Furthermore, you can see that the graft is already kind of orientated. You can see the asymmetrical cut very well, and it's rotating clockwise, so it's pointing clockwise, which tells me immediately that the graft is in the correct orientation, and hopefully it stays that way while I unfold the remainder of the graft. So here I'm finishing off the single stitch, and I'm trying to just flush a little bit with BSS and just see what happens to the graft, and fortunately it's unfolded almost immediately in the right direction, and I've had to do very little manipulation to unfold the graft. I've tried to place the graft mainly over the area where the corneal edema is, so I don't mind if it's slightly decentered as long as it's not way off into the periphery. Once I'm happy with this, especially with the view and the risk that the stain on the donor will go away eventually, I wanted to be quite quick in doing this bit, so I just wanted to place it slightly more centrally, and then I'm going to place SF6 18% to place the graft in position. So here I'm injecting SF6 18% and just filling up the AC with the Rycroft cannula, being very careful not to touch the graft. And here the graft is immediately in position. I'm just using a little bit of the Rycroft swiping technique just to move the graft slightly more centrally. And here you can see that the case has taken very little time, primarily due to the fact that the graft is unfolded in the correct orientation almost immediately. And I'm just injecting subconj, cefuroxime and dexamethasone.